usually starts in the teenage years. One eye, maybe both, they begin to blur. Not like ordinary nearsightedness, but in a way that's asymmetric, unstable. Glasses stop working. The prescription keeps changing. And the world starts to warp at the edges. That's not just poor vision. That's keratoconus. Keratoconus is a degenerative eye condition where the cornea, the clear dome-like outer layer, begins to thin and pushes outward, forming a conical bulge. It's not theoretical. It's physically measurable. A normal corneal curvature might average 43 diopters. In keratoconus, it can steepen to 60 or more. That shift distorts how light enters the eye, throwing off focus and creating visual chaos. One of the defining features is irregular astigmatism. In simple terms, it means the eye bends light in the uneven directions. Instead of a neat focal point, light gets scattered. This isn't the kind of astigmatism that glasses can fix. Even contact lenses often struggle without special shaping. So as the cornea bulges, myopia or nearsightedness also increases. The eye elongates in function, if not in shape, pulling focus closer and blurring distance. That means a patient might move from 20/40 to 2400 vision in just a few years, even with correction. While keratoconus usually hits both eyes, it's rarely symmetrical. One eye might show steepening while the other still appears normal on basic tests. And that asymmetry is part of what makes early diagnosis so incredibly difficult. The cause is unclear, but research has pinpointed a few suspects. Genetics, they play a role. Close relatives have a 10 to 15% chance of increased risk. Mechanical stress from eye rubbing can actually accelerate the damage, especially in people with chronic allergies. There's also a known correlation with the connective tissue disorders like Marfan syndrome and Ehlers-Danlos. That's where collagen structure is genetically weakened. Here's a lesser-known detail. The first modern description of keratoconus came from the British physician John Nottingham in 1854. He documented a young man whose vision deteriorated rapidly despite new glasses, an early cue to what we now recognize as corneal warping. Today, early diagnosis relies on imaging. Corneal topography creates a heat map of curvature and thickness. It can detect changes before symptoms even begin. Some schools now use these scans during vision screenings in high-risk regions. Treatment follows a stair-step path. First, rigid gas-permeable lenses, then scleral lenses, large diameter contacts that vault over the cornea entirely, resting on the white of the eyes. They're custom fit, often larger than 15 millimeters or 0.6 inches, and can restore functional vision when glasses can't. To stop progression, there's corneal collagen cross-linking. It's approved by the FDA in 2016. It works by applying riboflavin, vitamin B2, and exposing the eye to ultraviolet A light. This strengthens the corneal fibers like rebar in concrete, preventing further bulging. It doesn't fix the vision, but it locks the structure in place right where it is. In advanced cases, about 15 to 20%, patients need a corneal transplant. That means removing the damaged tissue and replacing it with donor cornea. Full-thickness grafts are rare now. Most surgeons use partial techniques like deep anterior lamellar keratoplasty, or DALK, which preserves the patient's own endothelium and reduces rejection risk. The term keratoconus, it comes from the Greek kerato, meaning horn, and konos, meaning cone. The name is purely anatomical, not based on cause, not based on symptoms. And here's the part that a lot of people just don't talk about. The condition hits when life is just beginning to focus. When a teenager looks at the road or a whiteboard and sees only streaks, it doesn't just affect vision. It affects confidence, academics, and the daily experience of clarity. Every successful diagnosis, every fitted lens gives that clarity back. These are Interesting Things with JC.